Hi everyone. I'm very pleased to be here. We're talking about Smartee Kinder and Teen, and for me, what are the best tools to use with aligners? Okay, at the beginning, I said, she already say, I'm from Mexico, but I have been living all my clinical career in Spain, in Madrid. So anytime you want to come to Madrid, you're welcome to do it. I will, like most of you, do braces, uh, aligners, everything. But 10 years ago, I changed completely my clinical practice only to aligners. Why? Because I saw that I can do anything with aligners because I know the biomechanics. So I will show you how to do the best treatment. And for me, what was the change that I had to make and how to improve the time when I use it. You know, Smartee is not a new company. Everybody thinks all the Chinese are very new or every aligner is now on the market is very new. No, it's 22 years of history and they have been developing all the time new technologies for us to use. For me, the best part is that it's made by doctors for doctors. As you know, I use many other trademarks. I use Invisalign, Spark, Angel, Sure Smile, Clear Correct. But for me, the only one that can give me and I can achieve the results I want now is Smartee for sure. So that's why I change all my practice to Smartee. As you know, it's more than 57 countries. I always said we have to renew this slide. But in China is a company that does more patents around the world. We already have three manufacturing factories, two in China, one in Spain. The one in Spain is for the whole of Europe, and they are making a new one in South America for Latin America, and another one I think in China. So we're growing really fast. You know that they have all the certificates, the FDA certificates, the Community of Europe certificates, but in all the patents I have, for me, there's one that is really important to explain. There's one certificate that says that this patent that the plastic of aligners with Smartee, it can be treated like food. It's allowed like a food that if you swallow a little bit of plastic, it doesn't happen nothing. That's something really good to know because, as you know, this doesn't happen with other trademarks of aligners. We have the license of Disney, obviously, for the kids and teen. That's the big difference. For me, for the marketing, it's a big difference. I don't know what about you, but I'm very all the time I'm in uploading things in Instagram and TikTok, and this looks really good, and the kids love it. How about the digital workflow? We have all the tools. If you know how to use aligners, um, you know all these tools. I will center for me in the most important um, workflows assessment. First, this template, the template of facet that is one and unique. No one has it. The oral health report, I will show you how. You know, we have in all the trademarks, the live 3D, but they don't have smart still with dental monitoring. We have an app to upload everything and to manage everything with the phone, to take pictures to the patient and upload it to the case in a review of the case. We have the iFast is a simulator of when you can upload the STL and to see how it's going to look. We have the self measurement is really important. You only can have to upload a CV, not a CVCT, an X-ray, lateral X-ray, and you will see everything. In 1 minute, you will have all the measures that you need. So and it's very accurate. Um, the smile simulation. Here, when you upload a case with the smile, and they will do the Smartee check, you can see how it really is going to look at the end of the treatment. And obviously, the root visualization. If you upload a CVCT, you can see the real roots of the case. First, about this template. For me, we have 3 templates. No one gives you these 3 templates. The best one for me is the acid template attachment. Why? Because we save 40% of the product, and also we don't have to make any damage to the rest of the enamel of the teeth, only decalcificate the exact point we have. And then you have 2 templates the first time you get an aligner. You have the soft one and the hard one. You can use any one you prefer. For me, I always use the hard one. Why? Because in kids it's better maybe to use the soft one because they move so much, but I don't like it. It's my preference. Why? Because I have to put always scissors in between to make sure it's not moving, that the attachment is in the best place. So for me, the good one is the standard one. But both are very good to use. If you're using the soft one, please be aware of not pressing the attachment, because if you change the shape of the attachments, you won't have the same results. Here, I will show you in a small video how I do in the clinic. Here is the way that you can use the AC template attachment. And as you can see, you put it like 20 seconds, you rinse with water, then you put air, and then here you put the bonding only in the side where you are going to use the template, okay? When you're going to put the attachment. So here it will give you no demineralization of the enamel. You would obtain 30% less time of chair time. For me is very, very important. And then when you put the template, as you can see, this is a hard template. This is the one I use. And I put it. First, I take out all the excess. As you can see, it's always an excess of bonding and composite. Here, you take it out, and then you put bond. You put the light to photocure, and when then you take this out, you will see that only in 1 minute, 1 second, you take out all the excess of the attachment. For me, this is very good because before I have to use burns and it takes me time. Now it doesn't. Another very important for me is the oral health assessment report. I'm sorry it's in Spanish, but for me it appears in Spanish because I'm in Spain. But this is something you upload only the photos and the x-rays of the patient, and you can have all this that you are looking in the other side. But for me, what is important in kids and teen is to know when is the spurt of the pubertal peak of growth. So, because you know that is a different when you're a class 2 division and a class 3. And also, for me, it's very important that I can see if the airway is narrow, because then I will have another problem. So you can have the spurt pubertal growth and the airways. And you can show and share everything to the patient. You can print it and give it to the patient. You will look more professional, and it will give explanation. And you can choose what to put in or not. Okay? And you can have cavities, demineralization, everything. And also they can recommend you what to use. So I really, this tool is very important, not only for us to use. It's a good selling tool that no one has, only Smartee, and I recommend it. About the trim line, we have different trim lines. It's customized as we want. The scallop one is the one that we always like, but I don't recommend this one in kids or teen. I will recommend the scallop extended trim line or the extend straight trim line. Why? Because the crowns of the kids are very small, so I recommend them to be bigger. Okay. Also, the distal grab. This you have to ask for it. As you can see, this for is meant to be for GE, but you can ask it in key 13, but you have to write it to your I'm sorry, to your CAD designer. Here it says about the second molar, but I do it for the first molars. Why do I use? If you want to change the occlusal plane, if you were used to use many removable devices like Raymond's device, and you want to change the occlusal plane, you can do it. How? You have to exclude the molar, the first molars of the aligner, not included, and then you have an extrusion of the molar, and then you can change the occlusal plane, and you can, in a class 2, make forward, not necessarily using an S8 device. And in class 3, what do we want to use is we won't include the first molars in the lower jaw, and then we will have the extrusion, and we will make more parallel the occlusal to the occlusal camber plane. Okay. Why do I use Smartee aligners? I have tried all the trademarks, and since 4 years ago, uh, they were introduced for me in Spain. But 3 years ago for me was a changing because I really at the beginning didn't understand really all the solutions. For me, it was so many solutions when with other trademarks, I didn't have all this stuff. So it was a little bit confusing. That's what I'm trying to explain now. First, if you are treating kids, you have to treat them from the beginning when they are very young. And Smartee offers me the way to treat patients with myofunctionals, aligners, and very complex cases. I do adults with surgical cases with aligners. So now that I can prevent or use GS not to do the patient the surgery, for me is the best. So, and I recommend you this. You prevent, guide and correct. But the most important for me is that it's a treatment made by doctors for doctors. I don't know if you know the trademarks, but the CAD designers are not doctors. In Smartee, all the 500 CAD designers are at least doctors, and most of them orthodontists. So you will get a Smartee check and a feedback that is real, and you will get a good simulation and a finish of the case. When is the best time to treat patients? I always say you have to go to the root of the problem, not only to treat the symptoms. If I have a patient when he's 14, 15, 20, 50, I'm treating the symptoms, but I'm learn with Dr. Plana's philosophy of RNO. He talks about genetic and epigenetic factors. So what do we have to do? With the craniofacial growth, we have genetics. There's nothing we can do about that because it's the inherit of our parents. But epigenetics or environmental factors, these are very important in kids. Very, very important. Why? There are 5 epigenetics that give us long-term stability with the occlusion. Breathing, it has to be nasal. Breastfeeding, I know you said breastfeeding. You know that when the kids are breastfeeding, they have to move the jaw forward and downward and forward. And that makes the craniofacial growth. Then the tongue. The tongue has to be resting in the base of the palate. So we have to create space and develop the mid face so the tongue have a space to be. The chewing. Okay, we know that after 6 months we need semi soft food to introduce to the kid. Why? And learn to the kid not to chew only in one side. It has to do bilateral. Why? Because if I'm only chewing in one side, I'm making, I will show you later, making better this size, but this, it will have an hypotonia of the muscle. The posture since 12, 2011, 19, they are recognizing that the posture is, it becomes of something about the mouth. So I always said to my patients, if you have a bad fit posture or a malocclusion, you will have a bad cervical problem, a skeletal problem. I will show you later. Okay, the products we're talking about are the ones in the below. This is kids, this is teen, this is teen. This is the packaging we can have for all the kids and teen. You can choose anyone. I think the packaging for me with Disney is better. What do we have? We have included all this in kinder and teen. What is the difference? Wait, I'm sorry. What is the difference between kinder and teen? S8, S9, and S10. Why? Because these are the solutions of mandibular advancement repositioning or maxilla repositioning. What do we have? I'm sorry. What do we have? Why choose Smartee? For me, these are the best things that no other trademark has. First, the mandibular advancement in kids and in adults. And it's very documented that we have two types of S8 as a twin block and as a herfs. The S9 is an occlusal ramp. It can be indented or flat. You know those patients that we have with a TMJ travel, or also that they don't have like a fixed occlusion, or we want first to deprogram the occlusion and before we use a Michigan and then we put aligners. No, we can do align and also have this. If you have the position correct, for example, this is the way of the occlusal ramp is, but you can ask for the ramp even though with a 45 degrees, so the mandibula comes back forward to this place, and then you make it indented, you will have the teeth falling in the same place in a class 2 patients. The myofunctionals, for me, are very important because I think we have to treat the root of the problem. And we have bitey, joy, joy, and smiley, smiley. I will explain everything. The S10 is for transversal problem and asymmetries. When they have a first contact and they shift. In kinder, teen, or adults, we can use this in teen and in adults, but not in kinder. You have to remember that S8, S9, and S10 are the difference between kinder and teen. With S15 and X16, we can use them with kinder also. They have an extra charge, but you can use it to use the face mask protraction of the maxillary. What is for me very important about this button? They have the hook and the button. For me, is that the difference between all the trademarks is that the button is embedded on the liner. It's not glued to a liner. So with Aero China Space, they find a way to do this button embed, and it goes through the liner so it can support very heavy forces to do the protraction, and it can be moved in different angles. The S11 and S2. The S11 is a transpalatal bar that can be but not nance button, I'm sorry, and a transpalatal bar. You don't have to do nothing. When you are distalizing, they will put a nance button. And when the 6 is in the place, they will change it and put a transpalatal bar. You only have to ask for S11. And S2 is a lip bumper. This lip bumper is I use it all the time in cases when I don't want to proclinate the incisors. When there's a class 2 division, the lower incisor usually are very proclined, so I think this is the best way to do it. Okay, the about the class 2 and class 3. We have to treat this at very early age, as soon as possible. You know that in class 3 we have convex profile, the protrusive chin, the mid face is a little bit protrude. We have so many times the three depths, as Professor Ganshen told us, deep upper jet, deep upper bite, deep curve speed. We will have maxillary compression and the tongue position will be low. That will give sometimes asymmetries. And in class 3, we have a concave profile, the prominent teeth, the mid face, it will be retrude, and usually we can have an anterior crossbite with a maxillary compression of the upper maxilla, and the tongue will be down. And this will give you so many times with asymmetries. Both of alterations, class 2 and class 3, will give problems with the eruption teeth, the swallowing, the speech, and the breathing. So we have to treat as soon as possible all of this, because if we only treat the symptoms and not the base problems, we will have patients with relapse. Okay? So what we can use with it, each one. For me, in class 2, this is what I use. S8, S9, S11, S15, and the S2, that is the lip bumper. I use also the tongue creeps and the upper tongue protrusion. The tongue protrusion, I will show you now what is it. And I will show you with the cases. And the class 3, I use S10, S11, S15, and the face mask. They will give you to choose two face masks, the one that is in the square and the one that is like this. So you can choose what do you want. For me, what is the best is that we can prevent to have and treat difficult, complex cases in adulthood. So as soon as possible, you start using myofunctionals and aligners, the better will be the treatment when they change the dentition. We're talking now about the Smartee product for growing patients. Okay, we have kinder and teen. Kinder is 2 years of aligner from 3 years old to 10 years old. It has to be primary, early, or mixed middle dentition. Not we Here there are patients maybe with 9 years old that is a girl that is very uh, fast growing that has all the teeth. Now, that should be in a teen. So you have to be in a mixed dentition, okay? Or a primary dentition. What can we treat? We have unlimited aligners for 2 years. Uh, we have retainers. For me, I don't use the retainers. I will prefer to use maybe passive aligners for some months only to sleep. Why? Because the kid has to grow and the mouth has to grow with it. So I don't like to block all the movement for a long time. Maybe 6 months will be enough for me. Um, what troubles we can achieve with kinder aligners? Anterior cross by, posterior cross by, scissors by, space, lots of space that we can recover, severe deep overjet, narrow arches, or ectopia. As you can see, almost everything. Here we are treating what I said before, the functional factors, breathing, chewing, sucking, swallowing, and pronunciation. So that's what we treat the patients as soon as possible. So here you have to prevent, intercept all the interference. If you have a good swallowing, breathing, the airways are liberated, the patient will grow better. About the attachments in kids are 40% smaller and they are in different shapes than the ones we use in adults. They are not very retentive and they are in the shape like curve, so it's not painful when they take it out. This for me is very important. Most of my patients has to have to go to the um, therapist of language. Why? Because they don't pronounce good the R, or they have a tongue habit, they pull it out or aside, or they don't swallow very good. So this is very good. And before, with the therapist of language, I had troubles. Why? Because with braces or big myofunctionals, it's very difficult to work. Here it's not. Here is like an aligner, and here you have a little bump. And the patient had to put the tongue there and learn how to swallow. And you can explain this to the therapist and work together with him. For this to work, you have to always uh, scan the palate, okay, of the patient, so we can have more space. And the tongue creep, tongue creep, maybe you don't see it. You can see it here. It's a little bit uh, spikes on the lower jaw, and you is it's not painful, but reminds the patient to up the tongue and move it forward. The trim line, okay, as I told you, we have the conventional trim line. As you can see here the tongue protrusion for the upper maxillar for the exercises. And you can be, uh, this is the one usually asked. This is in the front is like this, and in the backward is long trim line. I think that for me, it has to be in the front like this, and in the back high or higher, completely trimline straight. You have to use 24 hours the aligners like you do with adults. We have these three myofunctionals. The Joy Joy. We have 4 sizes of Joy Joy, and it's specialized in small kids with only primary dentition. Since 3 years old, you can use it. So here, as you can see, wait, let me put the volume. For molars. Here's gently you have to put to make it narrower. The insert it into like the whorl in the upper jaw into the grooves. Align the notch with the labial frenulum. This you have to align and be and see that it's not painful. Inspect the and then you have to inspect in the backward for any pressure. That is not pressure. If you need anything, you can cut it. And check whether the pad covering the molars is excessively long or causing. And if it's excessively long, you have to cut it in the back. And also you have to see that your papilla and the lingual side is not making any harm to the patient, okay? If any is present, okay, you have the joy for adjustment. Use it for sleeping hours and 2 hours in the day. What happens if you are using aligners and Joy at the same time? You have to use the Joy at night and the aligners during the day, okay? As we can see, this is how it works. You put it on and you have 4 sizes. You have to send an STL to use it, and you will have the size that you need. The myofunctional training, I said this is the Mickey Mouse bite because we have to practice 3 different movements. We have to practice the orbicular muscle, the labial muscle trainer, the tongue trainer, and the masseter training. What do we do? With the first, we have to bite so many, maybe 20 to 30 times, or 10, 10, 10, 3 times a day with the bite. Biting, as you can see here, the bitey with the teeth. This is to train the masseter muscle. Then we will have this. Biting the bitey, you have to put the tongue down, up, and up to another ear. And do it 30 times a day. Also, this is to train the tongue muscle. And the last one is the most difficult for the patients, is this one, because you have to put it in your lips, not with your teeth, only with your lips. And you have to pressure like this. And this, at the beginning, the patients cannot do it because they don't have the force of the labial muscle. So that's why we have to train them.
First, body.
As you can see,
the
this,
biofunctional trainer in your hand.
you always, when you get your package, you never know why is the strap. The strap is to prevent that the body falls. But it's very common because they don't have the strength to use it. So you can put it inside.
First movement.
First movement.
Bite with your teeth.
Bite with the teeth, as I told you.
Open and close your mouth
20 times. I do it 20 or 230, okay?
Movement. Keep bite in your mouth.
Keep it and then put your tongue out.
Tongue out for 20 times.
Okay, I do it differently. I do 20 times down, 20 times up, and 20 times to the other ear. And the other one is put it outside the lips.
Then open and close your mouth for 20 times.
Okay.
To let bite fall out of your mouth.
This,
at the beginning of the practice.
this is why they have to use the graph they gave us in the box of the beginning.
Then increase.
Everybody thinks that's everybody thinks that graph is maybe for the keys. No, it's for the body. So the patient put it here and it doesn't fall because at the beginning it will fall. The smiley, as you can see, is also to practice. Let me see, including to this muscle, the auricular muscle of the mouth, to help close when you have troubles with mouth breather, biting or sucking with the tongue. You have to use this.
Smartee, smiley.
How do you use it?
Guide for usage. Welcome to Smartee.
You just have to put it.
Myofunctional Trainer Guide. Meet our magical myofunctional trainer design.
You have two sizes. I recommend to use the big size. And also tell the tongue therapist how to use it.
Your lips to hold it.
You have to do it tightly, like 10 seconds. And then
we're going to start a tug of war.
Start all over again.
To pull the ring gently outward while your lips resist and try to keep the smile.
You have to do it at the beginning. Do it yourself.
Hold for
pull it for the kid. And then
increase the pulling force.
He will do it himself,
Out.
themselves.
Do 30 repetitions as one.
30 repetitions and is the same. The small one, I only use it in primary dentition. After mixed dentition, I always use the big one. So what do we have the solutions? As I said, we have the attachments, the tongue protrusion for the habit, the tongue habit, the tongue creep to remind the tongue to go up and forward, backwards. But remember, as for the spikes, big. They are not painful, I assure you. The Joy is not in the package. This is not included, but it's not no expensive. It has to be used with aligners. You can ask for a kinder or for a teen, and a Joy. But you have to scan to use it, okay? Let's see case. And I will show you how at the beginning, this was one of my first cases. She had no space at all for the lateral incisors, and you can see they were growing completely in the back. This is a simulation, and this is the end of the first stage. I know Smartee tells us to use the aligners every 7 days in kids, or 10. I change in kids every 5 days. And as you can see, the result is very easy. So I have it. Then, as you can see, I'm doing expansion and molars first. And what do I have to always in kids? I recommend you to leave one gap of 1.5 millimeters in the front and back of the canines, and in the lower ones, 0.5 millimeters. Remember, the canines are very bigger, very big in comparison with the primary canine. So we need the space for them to grow, and then it's very easy to close the gaps. Okay, so this is the final of the first 6 months, and then I have 25 stages, 5 months. Actually, it was not. It was 5 months. Why? Because I was trying these teeth to grow, but as you can see, it didn't grow very much. So I This is what I did. I did expansion. And now and we have the compensators with movement. Those compensators are active. They move the teeth forward, okay? And this is how she is now. Well, at the beginning. I achieved, as you can see, wait, I'm sorry, it moves forward. Let me see, okay. Okay, as you can see, I was trying to move this teeth only 3 months, because after stage 15, let me show you again. As you can see, 9, 10, 15, I ask for passive aligners. As you can see, there's no movement. So I use these aligners to like retainers, only for the night with the attachments on until the teeth start falling out. So this is the same. I am trying to align the lateral incisor, and as you can see from the beginning, this is the end of 14 months. You have to remember that 2 months is the time you go back and forward with the lab, so we have it at the clinic. But this is what I have. This is the beginning. This is the end of 1 year, actually real treatment. And as you can see, we achieve all the space. I have the shape of the mandibula as I want. So now I only have to wait for the new teeth to grow. Here we have Anais. In Anais, we have a straight, a very narrow maxilla. This was ectopic, and that's what the key of the problem for the mother. Here's the end of the treatment. 39 stages. Remember, I change the aligner every 5 days. So this is what I have after 7 months. I do molars and incisors first. As you can see, I'm expanding and moving forward the incisors and always leaving a gap in between the canines and the lower canines. This is the beginning. At the end, only 7 months. And as you can see, it's almost done. What I have to stop? Why? Because she have, as you can see, I will show, I asked for a refinement right here, but she has all the teeth falling down. Do you see it? So I had to stop after 3 months because of all the teeth were falling. So I prefer for them not to use nothing and then wait and put it again, okay? This is what I'm doing. I'm reshaping, giving more space for the canines and the premolars, and the shape is good. You will see that I put attachments in the front and in the back, but I will show you why. Because sometimes when I want the teeth from the back go to the front of the shape of the maxilla or mandibula, usually is in the lowers. I put it in the back. Remember that the aligners, the attachments are pushing the attachments, and then we get the force. So if I put the attachments in the back, I will get a better root movement, making the teeth move forward. So now is how she is. We're waiting for the teeth to grow up again. I don't take out the attachments. Why? Because I will use it again. And I'll try not to do a lot of harm to the enamel, as I only change the attachments that I really need in the new refinement. Let's talk about teen. Teen, we have 5 years aligners. You will say 3 to 16. What is the difference? The difference is that we can use mandibular advancement, mandibular retrusion, or face mask. In kids, we can use face mask, but has an extra charge. So I recommend to do Smartee Teen. We can pause the treatment two times in between of the treatment. So
Smartee cares about children and teenagers.
and you
That's why
have
we created Smartee Teen.
all the
A
packaging that
comprehensive
is
age-based
amazing.
orthodontic solution. Teen offers a clear, non-surgical solution. Correcting jaw positioning.
Okay, you can correct
same
the
time.
jaw positioning,
And yes,
the alignment.
better with being
You
especially
can protract the maxilla, and obviously it could be
Smart
fun for the
teeth.
teeth.
The smart, non-surgical solution for growing smiles.
Non-surgical, because if you don't treat a kid of class 3 and class 2 when he's young, you will have a patient for surgical aligners, okay? What do we have in teen? We have all these products. As you can see, we have all we had in teen, except this. S8 is for mandibular advancement. S9 is the plate, the occlusal plate. S10 for asymmetries. And we have the only retainer made in any trademark with a retainer for mandibular advancement. That's really important. So what we have here? We have 5 years of limited aligners with 2 breaks in the treatment in between from 3 to. So what happened? Imagine a kid. What I do, and I recommend you to do the same. I didn't do it before, but now I learn and I do it like this. All my cases now are teen. At the beginning, they were kinder and they were teen. Now everything is teen. And then I tell the patients, I charge for a first treatment with kinder, and then I will say, you will need a second phase. We usually do. And what I do is make the price shorter because I already pay the aligners, but they don't know. So I do within 2 treatments, charging 2 treatments, but I'm only paying one. So we have 2 set of retainers, and what can we do? Everything we did with kids, but also facial prognatism, a cluster, so division treatment. Here we guide, correct, intercept, we do everything. We change the facial structure of the patient. That's very important to know. We have the myofunctionals like we did before. We have all the functions. What is the difference? We have the tongue protrusion, the tongue creep, the aligner protocol, the trim protocols, but we have this, the mandibular repositioning is 8, 9, 10, 11, and 16. And the hook and the Smartee. Remember, for me, the Smartee button is better. When to treat the patient if you are with a kid? You know that we have the cervical vertebral maturation. You only have to put the lateral x-ray and you can choose. Class 3 patients has to be treated before in the first and second stage in CS1 and CS2. But class 2 had to do it in CS3 and CS4. Why? To get a better use of the elastics or of the peak of a spurt of growth. What happens if we don't treat this when you're kids? As you know, if we bite just for one side, we will get this side, the muscle, it will get bigger, so the condyle will get drowned and will get a canting, and this bone will get up. So we had an imbalance of the mouth because we have the working and the balance size completely doing the same job all day long. What we have to do is like this. We have to do the mastication and balance in both sides. So we had this kid chewing on one side only. We had the unbalance of the body and repercussions in the vertebra, in the teeth, in the rotation of the foot, everything. So what we'll get? This posture. If we don't align the teeth and we don't correct the breathing, the swallowing, we will get this kind of projection. We'll get with a posture of class 2 patients, we will get this posture, and with a class 3 we'll get like this. Okay, so please treat the patients as soon as possible. I need to show you that Professor Kanshen is the one who invented the aligners with mandibular advancement a long, long time ago. Since 2000, he started the clinical trials, he start cementing the twin block in between the teeth to do it. And after 24 months, he start doing it with adults. What did he learn? That the TMJ produces a remodelable of the mandibula and the condyle and the fossa, less of the fossa than the condyle. But as more as I pull down and forward, the more remodeling of the condyle I will get. What do I have to see? I have to see this. With kids, you can take it out to eat, but with adults, you cannot. That's yes. So this picture for me is very important because people can see. I show them. I don't I don't want this remodeling not to make. That's why we need 11 months, like we did before with twin blocks, to get the remodeling of the condyle. So we have these this is the difference, the primary difference between uh, kinder and teen, that we have the mandibular repositioning device. We also have a very specific topics when to use what, which one. We have the twin block is S8 SG The TB is twin block, and the HB is Herbst. So the wings will be Herbst, and the twin blocks will be TB. We also have here, I will let you this, is when this is a classification to do when we see what kind of maxilla and occlusion, which device they recommend us to use. Okay, the wax registration. Okay, let me explain that. In kids, now we achieve that they can make a virtual jump. If it's a small kid, I use the vertical, the simulation with them. But if for me it's in the peak of growth, I do the waxing. Why? Because I want to assure that I have the facial uh, straight and no asymmetries, and the patient is comfortable with how it's going to see with the mandibular advancement. Let me show you. This is Franco. It's a teen case. Now I learned it's a teen case. This is the way I show my cases every time. What I do, like the wow effect. But why is this? We have a deep curve speed, deep curve overbite, and deep overjet, and a crowding, and a retrofacial uh, maxilla, mandibula. And then I show the patient always this photo. I take a photo with the mandibular in advancement because the parents don't know that the kid has this trouble with the mandibula. So I show them and then they understand what I have to do. This is the wax bite registration I use. It has to be edge to edge. It depends. Here it was edge to edge almost. And we start. I use the S8 twin block, the lip bumper S2, and I put two mini screws in because if I didn't know if I will need that to do it, to avoid the proclination. I didn't do it. Here we have to use the liners every 7 days in kids. In adults, it's every 10 days. This is the end of the beginning of the first stage, 11 months, remember? And as you can see, I didn't use the bottoms for the tats because I didn't need it. And as you can see, this is the result. You will say, it's not, okay, this is how it ends, exactly as you can see it. And then we'll see a jump. This jump, the last jump, the 46, is not real. You won't get a liner with this. It's just for us to see how will be the second phase. So this is what we have to see when we finish the case. And this is what I show the patient after 11 months, how I improve the profile. Okay. And now he has to use, I change. He has to use an S9 and a class 2 elastics. Why? To intrude the incisors align and then to do the, as you can see, that's an S9 and class 2 elastics. Why do I do distalization if it's a class and I make an advancement? Because if I make an advancement, as you can see, I have to align, but I don't want to proclaim, so I distalize to correct the teeth without moving their outside the bone. Okay, here we have the staging. Now we have six. What do? We align, we expand, and we correct vertical. The three movements. We have auto-descending blocks that are very good. And in the second phase, you have to, if we have a height more than 3 millimeters, I will get blocks again getting down. If the height is less than 3 millimeters, I will get wings. But if the height is less than 2, I only get attachments with a normal aligner. With the HBA Plus, it's the same as I told you right now. Is the first phase and the second, use the aligners. But what do I have to expect? This is very important. The first 2 months, the patient is only to get used to do the aligners, to get used to swallow, talk, and everything with the aligners. At the beginning, I try to see the patient 15 days after, just to see how is he feeling about the TMJ and everything. But actually, I don't have bad feedback, never, but I do it. In the month 4, you can see if you take one aligner that you want, if you want the mandibular to go backwards, you have to force it. In the 6 and 7 month, I recommend in the 7 to take an X-ray, not a CBCT, only an X-ray, to see if the condyle has a second cortical, to see if it's growing. Sometimes I don't see it. But in the month now, you cannot retract nothing, the mandibular, even though if you push. So when it's in month 11, you do the second phase. What do I have to see in the month 9? As you can see now, that the mandibular, even though he tries, is not coming back because I have a new bone. So this is the mandibular. TV is twin block, and HB is hairs block. It's like the device of the hairs. We do it only in one jump, okay? The S9 biplane and the occlusal splint, as I told you before. What is the difference? I don't like bite jumps. Why? Because if I have a patient class 2, it will go more backwards, and I will get a better, a gross case of class 2. So I recommend in deep bite cases for the intrusion of the anterior, for enabling the curved speed and stabilize the jaw position. So this is the animation. When to use anatomical and not anatomical? I think anatomical when we have deviation caused by asymmetrical or unilateral mastication. Okay? And not anatomical when you have a straight profile, deep upper jet, deep upper bite, as I will show you in this case. This is Fabio. Now I use a tin. As you can see, it's a class 1 with a deep bite and no space for the lower incisors. This is the end of the 7 months. I do expansion and distalization, and I use transpalatal bar, as you can see, and distalization. Why? Because I don't want to protrude the incisors, and I will always leave. As you can see, first I put the S11, and when I have a space to align, they put me. I don't have to say, put it in stage 20. No, they put me the S9, and as you can see, I finish with my gaps for the future teeth. Only 7 months, and I get the curved speed resolved. The deep upper jet is completely solved. So I use, as you saw, they have this. The mandibular reposition is for asymmetries, for cases with asymmetries, when you have a contact premature and you want to use a face mask. What do we use it? For mandibular repositioning device with concave profile. And the integrated device, for me, the hook, I don't use it very much. I always use the Smartee button, but it's as you prefer, okay? And I traction with the Smartee button the maxilla. I will show you this key. In kids, I'm showing you here 2 cases. In kids, The first case is in kids, you can ask in kids face mask and mandibular protraction. Okay, it was a really difficult case. He was very small, so I cannot wait to do it later. He was very young, but I cannot wait. So, as you can see, I have no space. All the teeth are in a very bad shape, but I have a really big retrusion of the maxilla. So what I did, I did I did hooks at the beginning, but I didn't have a lot of retention. So I had to change after 2 months because I did only expansion. Only expansion. Then I have to put the Smartee buttons for the protraction and also class 3 elastics. As you can see, I needed more retention in the aligner, so I put it on a transpalatal bar to hold better when I protract and also when I use the elastic because I couldn't put attachments in the molars, okay? So I use the second refinement. Why? Because I have erupted in the lateral, so I have to change. And here I use more things. I use the face mask, the hooks, and the transpalatal bar. And as you can see, I'm making molars and incisors first. I'm making both movements, the protraction and and this is how it's now. He changed every 5 days, and as you can see, I always leave gaps in between the canines. It's completely aligned. Now, I asked this just to consolidate, as I told you before, as a retainer. I use this as a retainer, not the big, really retainer, because he only uses at night to sleep. But as you can see, it was completely solved, the trouble. I changed the attachments, it was in backwards to the front, and that's it. But now I have Patricio. It's the same case. It's a little bit older, but he was in the peak of growth. So I this case for me is good because I learned how to use all the tools of Smartee in one case. I have a class 3 retrosive maxilla, insufficient maxillar growth but narrow airways, an anterior close bite, and a canting. And I use all these tools and you can see what did I do in 7 months knowing how to use all the tools. This is the result after 7 months, 6 months. I'm sorry, I was saying 7 is 6 months. I use class 3 elastics, face masks, and aligners. As you can see, I have the S10, that is the occlusal blocks, the occlusal splints. I will have the transpalatal bar and the elastics for the class 3 and the face mask protrusion. This is him using how easy it is to do it in the consultation. You have in your practice. This is my patient using putting the uh, class 3 elastics. Then we are using the face mask. I like this face mask. I will give him the elastics. And then you can see he put the face mask. It's very easy to use. I like this face mask because it has a grab around the forehead and it's very easy to use. And he can put this very easy. And at night it doesn't move because of the grab of the neck and the top. This is the result after 6 months of treatment, obviously learning how to use all the tools, not like I did before, in stages. So after 6 months, you can see I have no problems with the airway flow. Now it's a class 1, it's aligned, looks like a different kid, completely. A different face, a shortener, he doesn't have, he breathes, he can swallow perfectly. So, and the Smartee device of GS is for retention. I don't use it in kids, but I have to say that this is very good. If you have any patient with mandibular advancement of any other trademark, ask for this retainer because this is what we need to use. So the difference is between kinder and teen. Obviously, kinder is only 2 years. Teen is 5 years, and you have all the solution for facial retrognatism, and you can stop twice the treatment, pause it, and you have everything. I recommend to use as a tip to use tin and charge the patient twice, not so much for the second phase, but you only pay one for the treatment. The solutions in yellow, what you can find in kinder, in blue, in tin, and what is an optional device with extra fee, like S11, the transpalatal bar, or the Smartee button is not included. The face mask, or you have to pay it, but you can choose which one you want. Recommend you always work with a speech language therapist and use myofunctional therapy. And okay, I give this to my patients, the mouth stripes and the anti-snoring. I'm sorry, and the anti-snoring. But first, we have to make the mandibular advance to have the space. Because if I close the mouth and he doesn't have the space to breathe, it's a trouble.
Welcome to the world of Smartee Kinder and
You can see the packaging. It's amazing. And now we have also
featuring Spider-Man's signature colors
Stitch,
and web slinging
that I love it,
graphics.
and
It's not just a
the
box.
packaging of
An invitation to an exciting orthodontic journey.
Iron Man
Inside,
is
the magic
amazing.
continues.
You have two boxes,
We have the specially designed
the
invisible aligners.
transpalatal bar. You have two boxes because if the kid has to stay at evening or the parents are divorced. The chewies are lovely.
Sure, the aligners fit perfectly. Next,
We have the myofunctional included. These two are included. This not, but if you need it, you ask for it.
Perfect for on-the-go kids. Finally, we have the aligner case.
And the aligner case, you have two, but you can have everything in both aligners, okay? Conclusions. First, please read class 3 cases in CS1 and CS2, class 2 and CS3 and CS4. We have solutions that no one else had. That's why I'm in love with Smartee, because they do everything really for what we needed. Use the myofunctional devices and the packaging of Disney. Take home message. Prevent. Everything is in the base of the travel. The breathing, the swallowing, and the chewing. And if we correct the malocclusion and we are correcting all this, we create good conditions for the growth of the patient. For me, Smartee has all the tools I need to use my knowledge, because we are orthodontists and we know how to do aligners or how to do braces. Now we have to combine everything, and they have everything with doctors. I want to show you that there's a book coming in English and in Spanish soon. You can have the QR code there, and I'll invite you all to Mallorca in the September 18 and 19. We are having the first European Summit of Smartee. You have all the speakers right here. As we have the Professor Ganshen, that I assure you he's the best. You will learn a lot of him. And that's it. If you have any doubts of questions, these are my ways of contact me of anything you need. Thank you.
Hello, everyone. If you have any questions, you can put your questions in the chat box.
Okay, let me see. You will tell me the questions, or I have to see it?
They don't put any question right now. I think it's
Or I
good.
explained very good.
Yeah,
I hope so.
I think they give you the thumbs up.
Okay, thank you, thank you.
Okay,
But don't
so
hesitate to ask. If you have any questions, doubts, write me by Instagram. You have my email there, and I will be pleased to help everybody. Okay?
thank you so much, Doc Isabel.
Thank you, Angela.
Have a good day.
You too. Have a good day, all.
Bye.
Bye-bye.